Thank you. So I'm going to try to go over topics that relate to how we calculate dose and then consequences later of perhaps underdosing patients. The most common method for estimating dose, which is really not anything to do with the dose to the patient, is the CT dose index. And this is generated in the radiology report and is specific to a system and its parameter settings for the acquisition. And you can see that it inherently takes into account multiple slices. So let's see if I can use my pointer on this. There we go. So this is the CT dose index for a multi-slice acquisition. And usually this is integrated over a 10 centimeter range axially. And then the CTDI wall is a combination or a weighted average of the central region and the peripheral regions. But again, this is not dose to the patient. And actually dose to the patient is a challenging measure. And then additionally, what you might see in your radiology report with the image is what's called the dose length product. And that's the product of the CTDI wall times the axial extent of the scan, which is trying to capture the coverage. But again, these are standardized for the phantom used for the CTDI measurement and just gives the range of the scan, not anything specific to the individual patient. The next step towards trying to get to a dose for an individual patient is to use this conversion factor, which enables us to calculate the effective dose. These numbers are actually generated for the average patient, though, and they're population based, right? So actually calculating the dose to a given individual patient requires accounting for the patient size, and then ultimately probably also patient specific factors. So we're really using these tools to estimate the dose on a per population level and on a per scanner basis. And the CTDI vol has become the standard because it enables us to compare different scanners and different parameter settings for those scanners across vendor platform models and makes. The AAPM low dose CT recommendations are fairly wide ranging. So there isn't really a specific standard for low dose, if you maybe have encountered that. They recommend in their document CTDI vol of less than 3 milligray as a kind of threshold for low dose. However, they report in a table in that same paper a range of doses that obviously require adjustment for the patient size, but also within that ranges for low dose that go all the way from 0.25 up to 2.8 milligray for a small patient, up to 1 and 5.6 for a large patient. So the sort of definition of low dose is fuzzy in and of itself. CT dose and risk. So from a medical physics perspective, we're always thinking about as low as reasonably achievable, the ELARA principle. And this is always putting downward pressure on CT dose in all settings. So we want to maximize the capabilities of our CT scanner to achieve the necessary quality of images but at the same time, minimizing the dose to the patient. So that as a philosophy is always driving the CT dose downwards. The linear no threshold model, which we just heard about in a lot of detail, I just want to restate that this has limited data to support low radiation doses, less than 200 millisieverts. And it's a very conservative model to assume that there's this linear relationship that goes all the way down to low doses. The strongest data for supporting this is the risk model from the lifespan study, which was based on Japanese atomic bomb survivors. And just to make the point, here is actual data from the low dose components of that study. You can see the error bars, and you can also see that there's this potential, what's called hormesis. So there's various models that take into account the potential of actual positive health effects due to low dose radiation, or a threshold model that would take into account DNA repair. So it's a very controversial topic. I thought I would mention this just because of our future discussion on cumulative dose and cumulative risk. I mean, one way to think about this is that there's potentially a non-zero risk that you would have an unlucky event and hit a key area in the DNA and damage that DNA that would then lead to a cancer. But you may be able to undergo multiple CT scans where that does not occur. And so this would just be considering, each CT scan as an independent event or independent roll of the dice with respect to cancer risk. And I just put in some numbers here to get an assessment of how that would work. So this is just a product of probabilities. And then what has been considered for the paper in JAMA is more of a cumulative risk model, where there's some conditional probability of, say, cancer at age 40, given a cumulative CT dose. And then this would be calculated as this dependent events model. And the model for this conditional probability, of course, in that paper and others, many others, is this linear no threshold model. So dose reduction in lung CT, if we push this too low, I just wanted to make the point that we run the risk of increased noise and artifacts. And this can generate reduced conspicuity and make it more difficult to detect lesions and reduce precision for measurement if we're looking for quantification. That would be, say, volume of the lesion and quantification of lung density and other biomarkers. And this is just to emphasize that. I think maybe the best lesion to look at is this one. As you move to lower and lower dose, you get to the point where the lesion itself becomes undetectable. And I included this table because it emphasizes that point I made earlier about what is low dose. These are all either lung cancer screening used clinically or clinical research studies that do longitudinal CT protocols in the chest. And they all consider themselves low dose. And the range of the CTDI vol, that's, is quite variable, right? So for our lung cancer screening program, we have CTDI vols that run from 0.52 all the way to 1.68 milligray. And then COPD gene, the early phases of that was using 6.1 to 11.4 milligray, depending on the BMI of the volunteer. That then went to a 3 milligray low dose scan subsequently in phase 3 and 4. Similarly, for the severe asthma research program, we had a comparable CTDI vol to the early phases of COPD gene. And then more recently, an extension of that SARP, which was an interventional trial, used a 2.2 to 3.57 milligray range. And I conclude these because I have these asterisks pointing out advances in CT technology that enable these low dose protocols to still achieve adequate image quality. So this is this interplay that's going on constantly between the dose that we're using and the quality of the image and the CT scanner advancing technology. And just to go through these quickly, the automated exposure control was the first major advance that enabled us to reduce the total dose. This modulates the exposure as a function of the axial position. And you can see we can increase the dose in this region to account for the additional attenuation of the shoulders, and then decrease the dose as we move through the low density regions of the lung. And this has consequent improvements in the image quality in reducing what we sometimes call as photon starvation, or a streak artifact that's manifest in these regions because of inadequate number of photons through these high attenuated regions. Here it's been sufficiently high dose in this region, and then reduction of dose still achieves the necessary contrast in the lungs. And then a second innovation that really advanced our ability to reduce dose but maintain image quality has been the iterative reconstructions and also deep learning reconstructions. And you can see here by honing in on that same set of images, this is a comparison of what is a exact reconstruction called filtered back projection. That's what we used to use routinely. Now with this new iterative reconstruction approach that's model-based, you can see the conspicuity of the lesion is improved. And then more recently, advances in photon counting. There's two ways that photon counting enables better contrast and lower noise. One is that you can actually quantify the energy levels of the detected photons, because now you're using a detector that, instead of approximating that energy through light, which is then radiated out, and then a photodiode picks up that light, you're actually physically detecting each photon coming in. This enables you to threshold out the noise level, and then subsequently can eliminate that. And additionally, you get better contrast at low energy levels because you're not losing those photons through that transfer to light. and this improves contrast and conspicuity as well. And then with comparable resolution and lower dose here halved compared to an energy integrating detector or conventional system, you can see these structures much better. All right, effective dose in millisieverts is to an individual is necessarily based on population averages and estimates of risk based on populations. CTD-IVOL and milligray is used as a standard for comparing CT dose performance across scanner makes and models. And AAPM defines low dose chest CT at CTD-IVOL less than 3 milligray for a average patient. And the linear no threshold model supported only for high radiation dose. We talked about that earlier. ALARA is always driving CT dose downward. So the real issue, if there is one, is the increasing number of CT scans, and evolution of CT technologies is improving resolution and contrast at lower dose. Thank you.